everybody to the 42nd edition of the Cameroon Town Hall for Healthcare Professionals. It's always good to see you all. I hope you're well. I hope your families are well. For those of you who've joined us here on the Zoom platform, you're very welcome. For those of you who are following us from your homes on social media, we send our warm wishes for 2022 to you, for those we haven't met since the year began. And I'm really, really excited because at today's town hall, we're going to be talking about an organ of the body that's often neglected. Oh yes, it's often neglected until one day you wake up and you realize it looks so tiny, hardly thought about by many people. But once you lose it, then you realize how crucial it is to your survival, how crucial it is to your day-to-day activities. And before we dive into the gist of the matter, I'm excited because I'm going to be hosting this town hall today with several of my co-moderators. I'm here with Christelle. Bonjour Christelle, comment allez-vous?
Bonjour Alison, bonsoir, en fonction de où vous nous joignez. Je vais très bien, j'espère que toi aussi. Et c'est un honneur renouvelé de participer à cette nouvelle édition de Cameroon Town Hall. Et merci à Dr. Nche d'avoir accepté l'invitation.
Merci Christelle. Pour nos téléspectateurs d'origine francophone, n'hésitez pas à poser vos questions parce que Christelle est là pour nous aider. I'm also here with Therese. Hi, Theresia.
Hi, Alison, and hi, everybody. It's always a pleasure to join the town hall. And I'd like to say thank you to Dr. Eleanor for accepting the invitation and to talk about this organ that is often neglected, because most of us neglect it. I neglect it. So it's going to be a lot of information for me to understand and digest it. So I've never really thought about it that much because I don't have issues with that part of my body.
Oh, our egoists will be joining us later. So we're referring to Elvis Dancy and to Brian Tegomo. I think they just enjoyed the soccer match so much that they are still in jubilation. For those of you who don't know yet, Cameroon just won the football match against the Gambia at the ongoing African Nations Cup. So it's a great celebration for us Cameroonians. So Elvis and Brian would probably be joining us later after the jubilations. Mais Christelle, toi qui portes les lunettes comme moi, qu'est-ce que tu penses de ce sujet d'aujourd'hui? Docteur Hélène, aujourd'hui, elle est là pour nous parler de problèmes de glaucome au Cameroun. Qu'est-ce que tu penses de ce sujet?
Alison, vraiment, il y a des choses qu'on néglige dans la vie, même si on est du corps médical. On porte des lunettes, mais on se dit que bon, ça va passer, mais c'est des éléments très importants parce que quand on perd la vue, c'est vrai qu'il n'y a pas un sens, tous les sens sont importants, sont indépendants, mais la vue quand même, c'est précieux. Donc, c'est important qu'on échange par rapport et ça va permettre de nous édifier, nous aussi, personnel médical dans ce domaine. Merci beaucoup, Dr. Eleanor. Et je suis très ravie. J'espère mettre à jour beaucoup de connaissances de mon côté et pour mon entourage ainsi que chaque participant. Merci, Alison.
Merci, Christelle. So you already have an idea, for those of you watching us, that our main speaker for today is Dr. Eleanor Ngwe, and we're going to be learning a little more about her in just a bit. She's going to be talking to us today about challenges posed by glaucoma in Cameroon. And her worry is that glaucoma is a silent cause of blindness that's often being neglected. Before we dive into the subject of today, we're going to hand the floor to our chairman himself, the Oga on the top, Dr. Foma Kene, to officially welcome everybody to the town hall and to give us some updates around what's happening in the world of COVID.
Wow, Alison, thank you very much. And I just want to say congratulations to the Lion. That's the first thing. I think they played their best game so far. That's my opinion. And I thought I was not this patriotic, but I'm trying to round in the hospital and I have my phone connected. So everyone was asking me what's happening and they keep saying soccer and I keep telling them football. So it's one of those things and I would like to welcome everyone who actually sacrifices time to come here for us to discuss about healthcare issues in Cameroon. I've said this time over again, the town hall belongs to all healthcare workers, nurses, lab technicians, scientists, epidemiologists, those who are sympathizers of healthcare, those who want to innovate in healthcare, those who are pharmacists, those who are even engineers and can give us solutions. Today, we're going to talk about an organ which looks very small, but occupies one of the largest parts of our brain. It actually occupies the whole occipital lobe of the brain. So it tells you exactly how important this is. We evolved to use our eyes. So if you want to deceive anyone about anything, try to take away their sight, then you see exactly what happens. So I'm very pleased, very honored to have had Eleanor to accept to come and be with us here today. She is someone I've known for a very long time, and I'm very honored for your achievements and also to get to see exactly what we can do in ophthalmology, especially. This is the first time we're talking about ophthalmology. It's the first time we're talking about glaucoma. There are so many things. I do put on glasses also. And maybe next time in a year or two, we talk about refractory problems in the eye. So I think that's something we can also talk about. So thank you very much. And Alison, it's a pleasure. And I'm really honored to be part of this wonderful movement, right, which we're having together. So, and I want to thank all the moderators. You guys are awesome. Without you, nothing can be done, but the town hall belongs to each and every one of us here. And if you know someone who is doing anything wonderful in Cameroon concerning healthcare, if you know about a problem in Cameroon that needs to be addressed, just let us know. Let any of the moderators know, and then we'll try to get someone to address it. Thank you. And Alison, without delaying, I will try to be as brief as possible so I give time for others to join. I'm going to just share a little bit about update. Brian works with the CDC. There are so many people here, and I'm so happy that we have had Cameroon has actually been able so far to organize the African Nation Cup and take into consideration that the player safety actually really is something we should talk about. We are each time trying to see if we've arrived the finish line. I don't know exactly if Omicron is going to be the finish line where we're going to turn this disease from a pandemic to an epidemic and later on to eradicate it. We don't know. Where I am in the US and everywhere in the world, you have these three divides. Those who are in denial, even physicians, those who are actually trying to be pragmatic, and those who are actually making the problem seem unbearable. So really, these are the kind of things we talked about this in the beginning, that in order to end this pandemic, we need to have strategy that it's holistic. We need to talk about mask wearing. We need to talk about therapeutics. I think 2022 is the year for therapeutics getting to do. We already got a vaccine, and this was the fastest vaccine so far that humans have developed. And I think this is a big, big way forward for us. And before 2020, what doesn't kill you makes you stronger. But after 2020, you see what doesn't kill you mutates and tries to kill you again. So we hope Omicron doesn't do that. And I usually tell people there are so many studies from Israel where Eleanor is, which they have been I think they have been the true scientists in the whole pandemic. They have been giving us data that doesn't lie, that show us exactly the way forward. Look, in schools here in the US and other places in Europe, there is this fight. Parents are now fighting against the government. So about issues of mask wearing, and the students are wondering why the parents are even fighting in the first place where they could even put on their mask. And unvaccinated people don't really deserve to die. After the vaccine was licensed about a year ago, we've had more than half deaths have occurred in the US in particular, also in Europe. We've had scientists who have been the strong anti-vaxxers. And if you see someone like Malon said he discovered the mRNA vaccine, why he did not. And people have not even gone to debunk him. This is what he played in the discovery of the mRNA vaccine, and everybody thinks he discovered. He had nothing to do with it. He did a little research when he was still a junior scientist. So we do know that vaccines do work. Against pregnancy, we have come to realize that COVID itself does not affect pregnancy, but getting COVID itself can also lead to complications during vaccination. And we've had several studies that have shown us a lot of things about protections that do occur, and that when mothers are vaccinated, they tend to protect their kids also, their unborn children. So we do know that in households in Israel, vaccinating the household prevents children who are below 5 years from getting infected with COVID. Here is the state. If you told me 2 years ago that you would have almost 400 million people would get COVID, I wouldn't accept. And that number is an underestimation, almost 1 billion. You have to multiply that number by 2. The number of people who don't even get tested. I'm a testimony of that. I had a lot of doctors during the Omicron surge who did not even want to go test, but had symptoms, kind of mild symptoms. They had been vaccinated. And here you can see the number in the world. You can see Cameroon, the number has not been drastic. We thank God for that. This is going to be a whole explanation about what is happening in Africa. We have given reasons, and we have talked about several reasons about this, and could be a debate, but we're thanking whatever reason be it that we don't have a lot of numbers. But I think we do have numbers. We have a young population. Travel within Africa is very limited. Once you turn to see South Africa, where it's more, this is a disease of the developed country, meaning the more developed you are, the more you're prone to get this disease, because traveling, one person can infect 100 people in New York City in the airport. So you get to see this. Now you get to see America is still championing. This is quite a shame that up to date, we're still debating the effectiveness of a vaccine which has been shown to be effective. We're debating the effectiveness of masks, which has been shown to reduce disease. China has shown us, we keep giving excuses how they're hiding numbers, but this has been shown before. Now we know with Omicron, the numbers are coming down in every state. So this is a good equalizer. Those who were shaming people who had corona have turned not to, because this is now affecting both the left and the right, especially here. So we're getting to live with it. And we're seeing that the numbers is not just an issue of being Black protective. South Africa is a Black country and has had a lot of cases because they're also well developed. And we saw the Omicron spike, and South Africa has a very good research background, and they were the first to identify Omicron, which is something I applaud, and I want other African countries to do. They should not be shamed. Looking at this diagram, you see how long it has taken us to get malaria vaccine. We started researching it since 1880. We just had one this year. And just to know exactly what we have done, COVID-19 vaccine took us less than a year. It's an outstanding innovation that humans, and now we're using that technology to get. They started an HIV trial that was 2 days ago on the mRNA vaccine, which is promising. So we'll get a lot. So those who tell me, oh, we have not vaccinated a lot of people, I want to see the number of cases. We've vaccinated 10 billion people. We've given 10 billion doses out. It's sad, but think about it. We're given 10 billion. There is no other vaccine we've ever given like this. We know that 1 out of every million person who gets the vaccine develops a clot. Can you believe that number? It looks like it's a big number the way the media blows it out. But you see, we're given 10 billion doses. That's a huge number. So you do see there is still vaccine inequality, which is occurring worldwide. African countries have less. It's a debate because countries like Cameroon do have more than the people want to take. So Alison, you have a big job to do with vaccine hesitancy. And we do know that it varies with income status from country to country, where the low income countries actually have less access to vaccine. We do know a universal vaccine is going to be the key to this, and there are companies that are working on this. The mutations that Omicron acquired, here we know from data from Israel, from UK, that getting a third dose, a booster, actually reduces your chances of dying from COVID. I'm going to show you guys a series of research quickly, showing you exactly what a booster does. And we did see this during this pandemic. My hospital was full the past 3 weeks. Now there's no one in the hospital. It's pretty empty. Everyone, no vaccinated patient died. None. All those in the ICU are unvaccinated, but there are people who still don't want to accept this. You see the data subdivided into age groups in Israel and in the US. You see that those 0 dies, even at the age of 8 to 45, you see those who are hospitalized and those who die, it's outstanding. You see, even looking at Israel, I can't read this language, but I think those who are in Israel, Eleanor, you could help us, but you see that those who are unvaccinated do get sick and hospitalized more. The data keeps showing itself, and it's the same data over and over. I'm just going to go quickly just to show you that this is what is happening. We're getting more children being hospitalized just because we're not vaccinating children from 0 to 5. It's not yet approved, but we're also hesitating in vaccinating children from 5 to 10. That's where the problem is coming. And we're infecting these children. Few of them really get sick, but a lot of them are actually getting into the hospital. This shows you the timeline of getting this vaccine. And I always present this to show you how far we have gone as humans. Now, if we're trying to get another vaccine, which is variant specific, is going to take us a shorter time. I think it's less than 3 months, we'll get one, if really we need it. But at the moment, we do not. We need a pan vaccine that can, any other mutant that comes up, we're going to be able to vaccinate. So variants are going to happen. New ones will come in. And we just need to learn to live our lives. You can see here where Omicron came from, how it actually differs from the other variants. And it's actually as transmissible almost as the measles, which is something we have not seen for a long time. So here's the Greek alphabet for the Greek soup, for those who don't know exactly how this is labeled. So you can actually think what the next name is going to be. You had Omicron, so you can actually look and see which is going to be Pi. Pi is too common, so they may skip it in order not to make things, so they do skip some. So here you saw when Omicron started, the world decided to lock itself off against South Africa, which was a wrong move. And it was shameful because South Africa proved that they had good scientists. They could identify this thing quickly, faster than a lot of European countries. And later on, we found out that Omicron was already in a lot of European countries circulating. So this is part of the racism you have in medicine. And you see at the beginning, they told us all the countries, they were mapping countries, but now you see it's everywhere, totally everywhere, it's Omicron. So we still have a cold chain issue. The US just sent a lot of Pfizer vaccines to Cameroon and other African countries. I think additional 400 million doses were distributed, were donated to Africa. So we do have a cold chain issue that we need to work on. There is a DREAM vaccine, which is a pan vaccine, which is being done in the NIH. They're trying to work on this. This is already in a phase 2 clinical trial. So we do know that therapeutics have not changed much. Now we have tablets that are efficacious, Paxlovid and Molnupiravir. These tablets have been FDA approved. They will be expensive. Maybe we'll not get them in Africa, but there is fluvoxamine, which can be used. Those who are in Africa and think it's an antipsychiatric drug with good data showing that it reduces severity of disease by 80%. So you guys need to know about this. This just shows you the two medications that are available, comparing them. This is their mechanism of action. And here we do see that Paxlovid among all antivirals is the one which finally I had this chart from the beginning, and Molnupiravir are two medications from Pfizer and from GlaxoSmithKline. Then we know Remdesivir is a glorified placebo. It works in certain cases. It's not approved in Europe, but we're using it a lot in the US. We do know corticosteroids and also interleukin-6 inhibitors, tocilizumab and baricitinib. We do know that some of these things do work. And we have this data, and we know that for the sake of being Black, being in Europe or in the US, you are all vitamin D deficient. It's always going to help to be supplemented with vitamin D and also vitamin C, but there is no data showing that this actually reduces mortality. Now, these other things were things that did not work. We do know that we're using monoclonal antibodies, but so far, all the other monoclonal antibodies in the US have been withdrawn except for sotrovimab, which is the only one which is still there because it's active against the Omicron variant. So here, I'm just gonna go fast to let you know that people have had patients who are sick even here and they are unable to actually get this Pfizer drug. This was an article that was released in New York Times. And back home in Africa, you can always look at the antipsychiatric drug if you have someone who is really sick. The good thing is that people are trying to still wear masks. Others are debating the mask issue, but there is evidence that masks do work. You can see that in Asia where they have a culture to wear masks and they have actually proven to us that it works. So people are shouting, wearing a mask makes you a tyrant, but the good thing is you're actually almost a prey to Omicron and it's going to lead to your death. So please put on masks, get vaccinated. I'm going to tell you that data actually has to help governments to justify their activities, and we should not get emotional and be data-driven. So please, this is the New England publication that shows us that vaccines do work during the Omicron time and even out of the Omicron time. So this is the recent data in terms of hospitalization. Vaccination, getting a booster reduces your chance of dying by 15%, reduces your chance of hospitalization by 11%, and reducing your chance of getting infected by 2.5%. The goal behind any immunization is to prevent deaths and sustain humanity for a long time. If we're getting there, please still get vaccinated. And Alison, thank you very much. Over.
Thank you, Dr. Foma. These are interesting updates. And I see Brian and Elvis have joined us. Welcome, welcome, Brian. Welcome, Elvis.
Thanks, Alison. It's great to be in the town hall again.
Elvis is muted. I think he was saying something.
Yeah.
Thank you, Alison, and thank you, Mono, for the updates. Sorry for being late. So it's a great pleasure being here. We are all happy Cameroon won the match. Thank you, Alison.
The performance, was it up to expectation, or or it was so?
No, they had a good game. They played the best game I've watched Cameroon play, right? I was so confident, and they never let me down. I'm happy they defeated the Gambians.
Awesome, welcome. And it's always good to have you join us. And now we're going to go ahead and introduce our speaker for today. I'm a feminist, and for me, when I see a woman taking lead in her field and making great strides the way Eleanor is doing, it's so inspiring. It's amazing to see her, leading the path, leading the way in her career path. And Eleanor is not just your average physician. Eleanor is not just your average, young Cameroonian, as you would get to realize in just a bit. So for those of you who have not had the chance to meet Eleanor before, she's a Cameroon-trained medical doctor. She's from the 36th batch of the medical doctors from the FMBS in Yaoundé, and she trained as an ophthalmologist at Hadassah Hebrew University Teaching Hospital in Jerusalem. And what I find very exciting and inspiring about her is that she's actually the first Cameroonian cornea and refractive surgeon. So if you have cornea or refractive problems that require surgery, and you are in Dr. Eleanor Ngwe Nche's hands, then you know that you're in good hands, because you're in the hands of someone who pays attention to details, someone who's an expert in her field and a leading practitioner. She's also the founder of Nka, which is an online platform for eye health education, and she's probably going to be telling us a little more about it in just a bit. Dr. Eleanor Nche, you're very welcome, and it's such a pleasure to have you. The floor is all yours.
Thank you, Alison. Thank you guys for inviting me to speak in Cameroon Town Hall. I'm humbled. It's a privilege for me. So you've said a lot. I try to tell my presentation to everyone here. I know, like you guys said already, we all went to medical school and we did 3 weeks in the ophthalmology rotation, and we passed around, and so I'll do my best to make it a little bit more fun than it should be. And if you will have questions in between, don't mind asking for clarification. That at the end of all of this, we will all go back home with something, especially with glaucoma that affects us a lot. And I hope at the end we'll have time to really discuss and talk and clarify a lot of things, okay? So I'm going to share my screen now. Okay, so this is a quote by Willard Scott. And like you see in the blurred image in the background, he says that it's simply a tragedy that anyone today should go blind from glaucoma, because it's really just so unnecessary. So we should have this at the back of our minds as we go through this talk. So let's look at this. This is a case scenario. Let's call this child Sigan, okay? So Sigan was born with these big, beautiful eyes. And the parents say, wow, she's so beautiful. The mom says she looks like Pocahontas. And the child grew up, and you can see here, this is Sigan in class. And you see her friends are looking at the teacher, and Sigan is really not really there, but she's in class. And during break, Siga doesn't want to go outside play because she complains that she doesn't really like to be outside. So is it that Siga is stubborn, or she's a child that doesn't want to study? We move on to the next situation. We're going to talk about this young guy. He's called Nkwanyong, okay? Let's just call him Nkwanyong. So Nkwanyong is a young guy. He just had his PhD. He's happy. And he majored in aeronautics, engineering. Wow, a great future, right? So Valentine's Day is coming. And last Valentine's, while Nkwanyong and his girlfriend were doing cash, he realized that while he was taking out one of the occluders from his eyes, he doesn't really see well in one eye. And then he recalls that sometimes when he goes outside, he has headache, strong lights, and he doesn't really like strong lights and strong sunlight. That's the second case. Now we look at the third case. We're going to talk about Mami Oben, okay? So it's 3 days now that nobody knew where Mami Oben was, and her body was found in a pit in the village. This was a pit that was found next to her toilet, and she got up in the night to go ease herself. Because she's been blind for many years, she fell into this pit. So Mami Oben also had all these many eye drops. It said that while she was younger, I was said that she had glaucoma, but you know, she doesn't really have someone helping her. She's been very confused on how to put this drop. She doesn't see. So every single case scenario I just shared is a true story that has happened to people I've heard about, and this is a story of glaucoma. So, and everything you heard is just portrays the ears of the hippopotamus, because there are many of such stories, and many people moving around like that have not even been diagnosed, because these people, you know, they don't have any symptoms and they don't know they have glaucoma, and you know, that's the gravity of the problem. So we're going to talk today about silent blindness and the challenges posed by glaucoma in Cameroon. I like to call myself Ngwe Nche. I came and learned that was an Israeli name. I have no financial disclosures. I'm the founder of Ndanka, and you can check me on Instagram, YouTube, most of the media platforms to see what we do there. Let's move on with our talk, okay? So what is glaucoma? Glaucoma actually is a chronic progressive optic neuropathy, even though it's in the eye, but we have to, I highlighted this so we should remember that it's an optic neuropathy, which is characterized by damage to the optic nerve and retinal nerve fiber layer, and it can lead to or central vision. There are many multiple factors that come in play before you can have glaucomatous optic neuropathy. It can be genetic, vascular, anatomical, or even immune factors. So a recall of how the eye looks like, right? So we remember you have the cornea, then the light goes in, you have the iris, the pupil, the lens. Pay attention to the ciliary body, okay, and the suspensory ligaments. And light is supposed to focus on your fovea, and just beside it, you have the optic nerve. And in the retina, you have what is called the retinal nerve fiber layer, which is not shown here, but it's actually like fibers of the optic nerve that are spread on the retina, okay? And this is what gathers the information from the light that fell on the eye and goes into the optic nerve and goes to the brain. So this is important to know, because we will see how all of this is affected in someone that has glaucoma. So most times when we hear about glaucoma, people always talk about high pressure in the eye, right? So what is pressure in the eye? We call it intraocular pressure, and subsequently you will see me talk about IOP. That's what it stands for. So it's a measurement of the fluid pressure inside the eye. I put normal in quotes because it doesn't follow, in a general population, it doesn't follow a Gaussian distribution. It tends to be skewed towards higher values. So even when we measure in the clinics and we say the range is from 9 to 21, which is normal, you can still have normal people with a little bit higher pressures. It just depends on who is in front of you. But studies show that the mean IOP in Africans is 15.5 plus or minus about 2.5. And this is significantly higher than in Caucasians and people of mixed ancestry. This is a study that was done in South Africa. So they looked at blacks, mixed blacks, and then they looked at Caucasians and found out that Africans had a higher mean intraocular pressure, okay? So what is the relationship between intraocular pressure then and glaucoma? We are going to see it here. So intraocular pressure level is one of the primary risk factors for the development of glaucoma, but it does not have a role in the definition of the disease. We'll see further down as in our talk that you can have people with glaucoma and normal intraocular pressure. And this is where the whole story of silent blindness comes, because you have people who are fine, but they have glaucoma. It all depends on how the pressure you have on your eye affects your optic nerve. So you can have a normal pressure, but your nerve doesn't resist this, and this normal in quotes pressure, and you have an optic nerve from it. So any level can have an impact on the risk of glaucoma. So what are the factors that affect intraocular pressure? Okay, so you have some factors that can increase the physiology of this. So you have factors that can increase intraocular pressure, and some factors that can decrease intraocular pressure. That can increase pressure in the eye can be like the Valsalva maneuver. Okay, you're pushing, you want to cough, or like you're holding your breath, or during intubation, you're playing a flute, or those kind of things. You touching your eye or rubbing your eye, putting pressure on the eye locally. Hormonal influence, like in hypothyroidism or thyroid eye disease. Drugs like corticosteroids who lead to increased pressure in the eye. It's important to note that when we do anesthesia with ketamine, the pressure in the eye goes up. And for us ophthalmologists, we know this like a reflex. We never want ketamine to be used in children when we sedate them to measure the IOP, because we know then the pressure will be high. And other factors that can decrease the pressure are exercise, pregnancy, some anesthetic drugs, and other things like alcohol, heroin, marijuana, okay? So how does glaucoma happen? So this is how the fluid in the eye is produced. More specifically, the aqueous humor. We remember that the front part of the eye is filled with aqueous humor, and the posterior part of the eye is filled with vitreous humor. So the ciliary body produces the aqueous that moves to the front part of the eye, passes under the iris, and then goes to the anterior chamber angle. There you have a filtration system, which is made up of the trabecular meshwork, and you have another alternative pathway, which is called scleral outflow, where you have like vessels that leave the eye, and then you have fluid that go through them and then enter the venous drainage of and leave the eye, or the trabecular outflow. So anything that will affect any of these processes will lead to a pressure buildup in the eye, and that's how the pressure in the eye goes up, as we'll see here. So if you have, it's like, let's say you have a house that has pipes, and then you block the pipes, the drainage pipes. What happens is you have an accumulation of the fluid, and if for it to come out, one of the pipes have to burst, right? So that's what happens with glaucoma. So you have the pressure buildup in the eye when the drainage channels are blocked, okay? And then this pressure buildup affects the optic nerve. That's why glaucoma is an optic neuropathy, and it's not really a pressure disease, and it destroys the optic nerve, and it leads to irreversible changes, okay? So here is just an illustration I want to show you when we talk of, so you have damage on the optic nerve, right? How do you see it? You've heard of we'll say you have an optic disc and an optic cup, and how you know this person has glaucoma. We look at the back of the eye, we look at the optic nerve, right? So this is a normal optic nerve. So this will be the disc and the cup. So a ratio of a measurement of the vertical height of the cup with respect to the disc is what we will call the cup to disc ratio, or the CDR. And in normal people, it should be less than 0.5. So you see here in a glaucomatous eye, you see here that the pressure on the optic nerve keeps eroding the optic nerve, destroys the optic nerve. It destroys the vascularization of the nerve, so the nerve dies. And this will be seen as a bigger cup with respect to the disc. So in most patients that have large cups like this, these are patients that have glaucoma. Putting aside people that, you know, normally have big discs, we have a lot of people that were born like this, but then I'll tell you later on how you can know that this is glaucoma, okay? So these are just real fundus pictures. Here you can see this is someone that had progression of glaucoma. So you can see this is a normal eye, then it progressed. You see that the cup got bigger, and here you basically don't have any nervous tissue here. The cup is basically here at the rim, and someone like this, you'll expect them to have just central vision left. So someone who has glaucoma, as it progresses, what happens? It destroys your vision in the periphery by destroying these retinal nerve fiber layers first. So this is normal vision. And someone that has early glaucoma, you see, they just don't see in the periphery. And you and I, when we move around on the street, we don't, you know, go around looking like, oh, how is my visual field? I see things in the periphery. No, you see, okay? So you have people like these on our streets who maybe even still driving, and they don't know they have glaucoma. And it's only when you have advanced glaucoma that you have what is called tunnel vision, that most people then realize like, something is going on, something's wrong with me, and then they go to the hospital. There are different types of glaucoma, okay? You can have what is called open angle glaucoma. You have what is called angle closure glaucoma, and then there's another set of glaucoma that is called childhood glaucoma. And most times when you hear about glaucoma, we are mostly talking about the adult form of glaucoma, because childhood glaucoma, it's not a glaucoma you're born with and then you grow up. Childhood glaucoma, you're just born with it, okay? And the glaucoma that we know of people that are 40 and above, these are people who did not have a glaucoma in their childhood, okay? And these different types of glaucoma can either be primary or secondary, meaning primary, you were born like that. You have, you know, genetic factors or intrinsic factors that make you have glaucoma. And secondary, meaning you have other things that contributed to you having glaucoma. For instance, like I mentioned before, corticosteroid use, trauma, and many other things. So what's the difference between open angle and angle closure glaucoma? In open angle glaucoma, it's blocked, right? But the angle, this angle, the anterior chamber angle, it's open. It's called the iridocorneal angle. It's open. And in angle closure glaucoma, it's actually closed. In this illustration, you see here that it's, let's say, a lens that is pushing on the iris that blocks the angle, but it could be something else. It could be someone that had inflammation in their eye, and you have synechia, okay, blocking the angle or blocking this part of the iris, connecting the iris to the lens, then the fluid builds up and it doesn't drain, and that will be angle closure glaucoma, okay? So when you go to the ophthalmologist, what do we see? It's said that in ophthalmology, we see things. We are the only people in medicine that see stuff. We see everything we need to see. We don't need to send you to, you know, do blood tests for us to figure out what's going on. We see it and that's it. So my on this side is an open angle. So you can see here on the upper part, you have the cornea, you have what is called the Schwab line, you have the trabecular meshwork, and then you see the iris root, right? Which is very different from this person that has a narrow angle. So here you can just see that the different lines here and the different layers, you don't see them at all, right? So if like this will step into a clinic, this person, and we do gonioscopy and we look at the angle and we see this kind of configuration. We know this is someone we want to start doing something on, and we don't wait for him to come at 2 a.m. in the middle of the night, in the hospital in Cameroon where no ophthalmologist is on call, and he has this pain and he's destroying his optic nerve and nobody knows what to do. So this is the time to treat. But this is another type of glaucoma which is not really common in our setting. So we'll see this later on. So in open angle glaucoma, you can have what is called glaucoma with high pressure and glaucoma without high pressure and glaucoma with high pressure. So glaucoma without high pressure is often called normal tension glaucoma or low tension glaucoma. Like I said before, these are people that are moving around. They don't know they have glaucoma, okay? They go to the ophthalmologist even when to check, or an ophthalmologist will check the optic nerve. But let's say most of the people we call eye doctors back home are opticians or people who are not really ophthalmologists. Okay, he did pressure and pressure was fine. He's like, you can go, everything is fine. But they have glaucoma and it's progressing. And then you have open angle glaucoma with, I made a mistake. This is with high pressure and it's called primary open angle glaucoma. And this primary open angle glaucoma, that is the problem. This is the public health problem. This is the glaucoma that everyone talks about. So we'll move on to the next section. Who is at risk for glaucoma, okay? So we have people older than 60, Black African descent. From the moment you're that melaninated brother or sister, you are a risk factor. You just being Black, that's a risk factor for glaucoma. A family history of glaucoma, if you have parents, siblings, or people in your family that had glaucoma, you are at risk for glaucoma. Steroid use, I mentioned before, diabetes, myopia. Okay, so myopia is a refractive error, right? Short-sightedness, and there are different levels of myopia. If you have glasses and you know your numbers and you have numbers that are higher than 6, you are at risk for glaucoma. Hypertension, a central corneal thickness of less than 500 microns. Why? Because when we measure pressure in the eye, most of the methods, we use what is called indentation. And a thick cornea means that it's around 535, 540 microns in thickness. And a thick, you will need much pressure from the machine to indent a thick cornea. It so happens that us in the equator, we have thinner corneas, and people who have thin corneas, they're at risk for glaucoma. Why? Because they might have high pressures, and when they go to the doctor, the measurement is done and the pressure in the eye seems to be normal because the cornea is thin, the machine indents the pressure, the despite high pressure, and so this glaucoma is not often picked early. Another risk factor is eye injury or sleep apnea. So all the people who snore, all the people who get up in the middle of the night because they got sleep apnea, they are all at risk for glaucoma. Why? Because of high perfusion when this happens, and that damages the optic nerve. So for us Africans, Black Africans, right? Glaucoma happens at a much earlier age and has a very, very aggressive clinical course compared to other people in the world. We see in this paper that looks at the prevalence of glaucoma in the different ethnic groups. And here we see that we have glaucoma happening in young people in the Black non-Hispanic population. We have the highest percentage, that the prevalence is higher in all the categories. You see here, this is the group 40 to 64, we are topping the charts. Between 65 to 84, 85 and older, we are topping the charts. So we have the worst, we are those people that are at the highest risk for glaucoma. It happens early, it's aggressive, and we generally don't care about such things. Glaucoma, eye things, that's not our business. If it's not hypertension, it's not diabetes, we don't go to the hospital. This is just to show the difference between primary angle closure glaucoma and primary open angle glaucoma. Again, it's to show that primary open angle glaucoma, the typical patient is more than 40 years, they are African, and they are male, which is different from primary angle closure glaucoma, which is common in Asians or people less than 40. This is a report on the prevalence of glaucoma in people aged 40 plus. That was in 2010, reported according to WHO sub-region. And again, we see here that our numbers in Africa are high for open angle glaucoma and even for open angle glaucoma, sorry. And as I said before, angle closure glaucoma, it's not really an African problem. This is something that's more common in Asia and in the Inuits, the Eskimos in the northern part of the globe. In Cameroon, we have studies show that we are overboard. So if in Africa, the prevalence is 4.16, in Cameroon, between 4.5 to 8.2%. So our numbers are not good. So I said before, primary open angle glaucoma, this is what is the global public health problem. It affects about 60 million people, and it's estimated by 2040, more than 100 million people would have been affected. It's the second leading cause of blindness after cataracts, but is the first cause of irreversible blindness. Cataracts can be treated, but glaucoma, the damage done, is always irreversible. And this primary open angle glaucoma is responsible for 15% of all blindness happening in Africa. And when I talk of Africa, I'm talking about Africa south of the Sahara. Here is a map that shows you the estimated regional prevalence of moderate and severe visual impairment and blindness due to glaucoma 2 years ago, and that's 2020. I put this just to show you that when we talk about moderate and severe visual impairment, that's someone who sits 6 meters away from a visual acuity chart and will not be able to see everything that I covered here. So they read from this and above. This person will not have a driver's license. This person's life is impaired. And you see here where we are in Cameroon, we are having the worst numbers. This is sub-Saharan Africa, the part that is affected most in the world, but we in West and Central Africa, that's where the burden of the problem lies. So what explains all of this? Why is it bad in Africa? Besides the genetic part that we are at higher risk, we have poor awareness. Few people know what is glaucoma. Okay, I heard my uncle had glaucoma. Okay, yeah, so he had glaucoma, so what? Most of us think that losing vision and losing sight is a normal part of aging. So if someone is going blind, okay, we look for a stick and give him, and that's it. Okay, you continue your life. You've lived, okay, so you're blind, so what? We have poor access to care. We have the many problems that we all know about. We don't have doctors, we don't have hospitals. Even when we do have, we are not equipped, leading to suboptimal diagnosis and management. We have our poverty problems, you know. We have to pay for every form of care. Most people cannot afford this. All of this leads to late presentation and the gruesome figures that I just showed. So because of all of this, in Africa, when they talk of the silent thief of sight, this is not in Europe. This is a problem that is specific to Africa, because it's in Africa that people go blind and they don't know they are going blind, and they show up at the time when the doctor tells them, you know, there's really nothing we can do, and then it becomes such a big problem. So how is glaucoma diagnosed? Let's move to the next section. The clinical presentation in children is quite different from that of adults. I'll explain in a few words. In children, they are growing, the eye is still elastic, and so the eye will tend to have changes that are very different from glaucoma in an adult person. In children, there's what is called a triad of glaucoma. It's called epiphora, blepharospasm, and photophobia. Epiphora is excessive tearing, okay? A child that is tearing all the time, want to, you know, that's a child you need to take to be checked, okay? It could be other things, it could be an obstruction or that, but if you have epiphora, blepharospasm is involuntary or excessive blinking, you know, you have these children that are blinking all the time. Why is the child blinking? There's pain, okay? And that's the child's own reflex of having that pain, but children don't complain. So, or photophobia, like I said in the first case I presented, a child that doesn't want to go out to sunlight. They go outside and they just want to come back in. I don't want to go into the light. I don't want to be outside in sunlight. That should raise that should make us alert that something is going on that's not okay. Other symptoms that can be seen: irritability, they cry when they go outside, a red eye, changes in academic performance. One thing that many people don't pay attention to. Working as a GP, we've had several complaints of, this child is not sitting well in class, and sometimes the parents come and they say, the doctor even gives like, I want you to write a letter that my child will sit in front of the class, but nobody ever goes to check why these children have to move from maybe the back of the class to the front of the class, why a child who was doing excellently well in school, all of a sudden their academic performance is going bad. These are all things we should check. Check vision. Maybe this child is in class and this child doesn't see at all. And these are things that we should be alert. We should have these things at the back of our minds when we hear this. In adults, the patients can come with pain, with redness, but not always. Sometimes they will tell you like, I'm looking at lights, I see like a halo around it, or I see like a rainbow around lights each time I look at the bright light. It's a signs of glaucoma or different forms of altered vision to vision loss. When this is happening already, this is already not a good thing. Other things can be blurred vision, photophobia, headaches, like I said in the second case I presented. And when we're taking history in the glaucoma patient, it's very important that we should take note for diabetes, hypertension, sleep apnea, migraines, neurologic diseases, pregnancy. Why? Because of glaucoma medication. That needs to be changed. If you have a pregnant woman that has glaucoma, you should have something ringing in your head that we need to go through her treatment, if at all she's taking treatment or not. I'll mention it later on. Family history. If someone comes to you and you're thinking, oh, this person has glaucoma, or even if you have, a patient that comes to you for something else, and you so happen to know they have a relative who has glaucoma, this is something you should want to look into. In children, if they have a relative that had glaucoma when they were a child, that's a high risk for glaucoma. And the risk is highest when you have a sibling. It's lower than, like, the risk for having glaucoma, it's higher when you have a sibling that has glaucoma than if you have a parent that has glaucoma. And of course, other systemic and ocular diseases. And as for a medication, I want to signal again, corticosteroids. Many people think that steroids are bad only when you take them systemically. No, I want to raise the awareness on asthmatics. We have a lot of asthmatics because of their asthma. They're using a lot of corticosteroids and they have developed glaucoma, and nobody's looking at this. We just keep treating the asthma, steroids, and nobody's looking at the eyes. Okay. So for the child, what do you want? I will stay with what everybody can look at and spare you some of the very ophthalmic things. Ophthalmos is actually the Latin name for a bull's eye. So this is the child, the picture I showed in the beginning. Now, when you look at it, you see that this child's eyes are huge. You see that the cornea, which is the clear part of the eye, is almost covering the whole eye. A normal corneal diameter in children is usually between 9 and 10, and as we grow to adults, it should be between 11 and 12. And if you see this, you see that these eyes are so huge. They shouldn't be like this. I put this picture here so we can see the difference. If this child had both eyes like like just the right eye, we might not pay attention to it. But here you see the asymmetry. This is a normal eye, but this eye is huge. Why? Because in children, they are still developing. So the more the pressure in the eye, the more expansive the sclera will be, and the eye will grow bigger and bigger and bigger and bigger. And so in children, we will not see the changes that we see in the nerve in adults, like all the erosion and all of this. We will not see this because the eye keeps growing big and creating more space for the nerve. So the nerve takes a long time to get destroyed compared to adults. Epiphoral blepharospasm, I talked about that. Corneal clouding is what you see here. You see these eyes that look like they are bluish. Some people say, oh, you have beautiful eyes. No, that's not a good thing. And of course, high pressure. So the ophthalmic evaluation that I will spare you, when you go to see an eye doctor, this is what should be done. Refraction, the numbers, like I said, there's a link between high myopia, high short-sightedness, and glaucoma. Tonometry is measurement of the pressure in the eye. Pachymetry is measurement of the corneal thickness. Gonioscopy is looking at the angle. Is this person at risk for glaucoma? Is the angle open? Do they have inflammation in the eye? There are different things we check inside the eye. Biomicroscopy is the slit lamp exam. Cataracts, you want to look if the person has cataracts. There are some glaucoma that happens because the lens from the cataract is so big, it pushes everything in front and blocks the angle. And of course, the posterior part of the eye that all of us should be able to do with at least a direct ophthalmoscope. So what are the characteristics of a glaucomatous optic nerve? The cup-disc ratio, if it's more than 0.7, the chance that a person has glaucoma is 95%. You have a 95% chance that a person obviously has glaucoma, okay? And if the rim doesn't obey the ISNT rule, what is the ISNT rule? ISNT stands for inferior, superior, nasal, and temporal, okay? So this is the optic nerve, right? So this is inferior, superior, nasal, and temporal. Normally, this inferior rim should be the thickest, followed by the superior rim, followed by the nasal rim, and followed by the temporal rim. If you find in any person that you have thinning, which usually starts first in the inferior rim, then the superior rim, and like that, the ISNT rule, it doesn't follow that ISNT rule in terms of thickness, that's a sign that that person has glaucoma, okay? Other things that you can see are generalized or focal enlargement of the cup, like we can see here. Disc hemorrhage, if you have bleeding on the optic nerve within 1 disc diameter, this is a diameter of a disc. So an area that corresponds to 1 disc diameter, within that you see blood, that could be glaucoma. Thinning of the neuroretinal rim, like you see here, you see this cup is so huge. This part, this is a normal eye. This is the same patient, this is the left eye, this is the right eye. You see this is the neuroretinal rim, which is supposed to be this thick for him. And here you see it's so thin. This is typical of glaucoma. Asymmetry, you can see this just at a glance. You see here, if I would say, okay, what's the cup-disc ratio here? We will say maybe 0.3, 0.4. And here we'll give this person maybe 0.7, 0.8. You see, this asymmetry is very typical of glaucoma, and loss of fiber layer that I wouldn't bother you with. So what other tests can be done? Okay, we look at this. This is for people working in eye health. What can be done? We can do either an A scan or a B mode ultrasound. For an A scan, it's for children that you want to see that the eye is big. A normal eye is just 24 millimeters long, so 2.5, 24 millimeters long, that's the length of a normal eye. If in patients that have glaucoma in children, it's usually 26, 30, and there you can say this person has glaucoma. For a B mode ultrasound, here you can see this is someone that has angle closure glaucoma, and here we can see clearly that this is the cornea. Okay, this is the sclera and this is the iris, and here you can see the iris that is apposed completely on the cornea because the angle is totally closed. And here it's an ultrasound of the whole globe, and this is supposed to be the shadowing of the optic nerve. And through the B mode, you can look at a huge cup. The diameter of a normal optic nerve is 1.5 millimeters. And if someone has a cup already of 1.2 millimeters, inside 1.5 millimeters, that should be a really huge cup, and that's very, very suspicious of glaucoma. The next thing we can do is visual fields. And visual fields are just a representation of our visual fields. I don't know how to put it. I don't know of a better way to say it. So here in a normal person, this will be the blind spot, which corresponds to the optic nerve. And you see, we don't have it, to make it simple, okay? Dark is not good. So if you see these dark spots, these are parts the patient didn't see. So during the visual field exam, they couldn't press on the light that was placed in that spot, okay? So these dark spots here, which corresponds to patches in their vision, which is typical of early stage. Usually people don't come at this stage, except they have, they are so aware, or they went for screening. They usually come here where you have this arcuate defect corresponding to the nerve fiber layers that are on the retina going into the optic nerve. You see, corresponding to moderate glaucoma, and in an advanced case, the visual field is like this. You see, peripheral vision gradually going to the center, and here they have just what we call tunnel vision. Another test that can be done is it's called the optical coherence tomography, to look at the retinal nerve fiber layer. So here, first of all, on this infrared image, we can see the asymmetry. If you look carefully, you see here that the cup that we're supposed to see in the middle, here it's quite good, but here it's pretty large, and you see just a thin rim around. Now, if you will look at this picture and just think about, say, it's just a regular graph, but in terms of thickness, okay? We'll see here that this is normal thickness. The machine does a good job for you and puts green. Green is a good thing, okay? And this is normal. But here, if you compare both sides, you see here that this is so thin, it's not within the normal limits. And as like I told you, the isn't rule, it's always the inferior and superior that are affected first, then the other parts follow. So this is not good, and it's very, very suspicious of glaucoma. If we have a patient like this, we'll start with aggressive treatment already, and and we'll also use this as a follow-up to see their progression with time, okay? We cannot go back, but we want to preserve the patient's vision so it doesn't go worse. We want to slow down progression. So how do we treat glaucoma? I'm talking by myself, so I hope you guys are following, because if you have questions, you can ask, or maybe in the end, I don't know what the moderators prefer. So, okay, so what's the aim of glaucoma treatment? I said before, glaucoma is an optic neuropathy. It's reversible, it's progressive, and there is nothing like I had glaucoma, now I don't have glaucoma anymore. You have glaucoma, it's a lifetime disease. So the aim of the treatment is to preserve visual function by lowering intraocular pressure to a level that is likely to prevent further optic nerve damage, okay? So it's like, we met you at this point, okay? We are not going back, we will keep going ahead, but we want to maintain this to be as healthy as possible and to preserve your vision as we can till you die, okay? So there's nothing like, oh, my nerve fiber layer got better, or my glaucoma got better, or I had glaucoma, now I don't have glaucoma anymore. There's nothing like that, okay? So the more advanced the disease at the time of diagnosis, the lower the target pressure. So glaucoma specialists have what they call target pressure, and they do this for every patient that goes to them, and they create a target pressure for you, and they want to monitor you to make sure they keep your pressure at that level for a very, very long time, so they preserve your vision. So the treatment regimen, like I said, is a long-term treatment. The choice of treatment for every patient will be the treatment that will have the lowest risk for adverse effect events, as we'll see for the types of treatment that is used. We can create a lot of adverse events depending on the patient in front of us. The treatment that will least disrupt the patient's life, okay? Let's say someone is a tailor, or it depends on the patient in front of you, okay? I'm a medical doctor. If I will go for glaucoma treatment, maybe they will say, okay, you might not have time during the day to put your drops 4 times a day, so let's just go and do surgery, okay? So we want to give the treatment that least affects the patient's quality of life. And also the cost of the treatment, because it's a long-term treatment. You don't want to start with treatments that are so expensive that the patient takes them for 1 month and that's it, then it's useless. So the different types of treatments can be medical, surgical, and for the medical treatments, we have eye drops or topical treatment, and we have systemic treatment. For the eye drops, we use prostaglandin analogs, beta-adrenergic antagonists, carbonic anhydrase inhibitors, adrenergic agonists, and parasympathomimetics that are not really used much nowadays. So the things I want to highlight, because we will see these patients that come to us, especially for those of us working in primary care settings, that to take note in patients who will be coming with beta-adrenergic antagonists, that in asthmatics, we know what that can do, right? Bronchospasms. For people who have cardiac problems, this will all cause bradycardia. So you want to be careful how you use that in these patients. And for adrenergic agonists, these are contraindicated in infants and young children because of the CNS depression it will cause. It will cause apnea, it will cause hypotension, it will cause bronchospasm, and this is not good. And for the systemic treatment, we can use Uramox, which is commonly called acetazolamide, which is commonly called Uramox or Diamox. And in some extreme cases where we want to have, we are not able to control the pressure with all of this, we have gone as far as giving drips of mannitol just to reduce the pressure in the eye. This is because of its hyperosmolar effect that it will have on the vitreous. Few words on glaucoma and pregnancy. So I said before that pregnancy will normally lower pressure in the eye, okay? But it's important to note that all glaucoma drops except for brimonidine are pregnancy category C. So if you have a pregnant woman coming to you and they so happen to have glaucoma, go please and check her treatment because of the teratogenic effects that it could have, especially in the first trimester of pregnancy. So this is something we always have to be alert on, okay? And for the surgical treatments, we have you can have incisional surgery, you can have lasers. The lasers that are used, the principle is the same. We want to create a connection between the posterior part of the eye and the drainage system, okay? So the lasers are either creating holes on the iris to let the fluid flow into the anterior chamber, or opening the trabecular meshwork and the angle to let more fluid leave the eye. And it's the same principle for surgeries. I'm trying to simplify it, but it's not as simple as I'm saying. Connection between the eye and the outside, like you have fluid, okay, you open the pipes and you make the fluid go out. Trabeculectomy, that's what's done. There are other glaucoma surgeries that consist of inserting tubes, and then you have like they create a flap below the conjunctiva where the fluid collects and drains posteriorly, but that's the idea behind surgery. So I brought this because everyone is talking about this nowadays. You go on social media platforms talking about marijuana for my glaucoma, you know. So what is this? You have a lot of people who say, oh, I have my medical marijuana because I have glaucoma and all of this. What about marijuana and glaucoma, okay? Few words. Does cannabis really treat glaucoma? So cannabis is made up of two main parts. You have the cannabinoid, or what's typically called THC, which actually lowers intraocular pressure, but the effect is short lasting. It's usually like 3 to 4 hours. These were studies that were done like in the, I think the 70s or the 80s, that people smoke cannabis and they check their IOPs 3 to 4 hours after, and yes, it lowered the pressure. But THC is the main psychoactive constituent of cannabis. Just like alcohol also reduces intraocular pressure and the effect lasts for like 1 hour. So is this enough to say that we should go ahead and use cannabis to reduce intraocular pressure. Now, the other sequence in cannabis, which is CBD or cannabidiol, may even increase eye pressure and make glaucoma worse. So cannabis is not a practical method for treating eye conditions. Recently, there was a survey that was done and it was shown that so many people, even some healthcare professionals, had these social media platforms where they were advocating for the use of cannabis. But when studies were done, either these people were not eye specialists, or these were things that were recorded like ages ago when this new data was not available. And to finish on this, cannabis is not recommended by the main ophthalmic organizations in the world for glaucoma treatment, okay? So please don't tell your patients you can have your banga to reduce your pressure in your eye. That is just not something anybody should do. The amount of THC you need to consume in order to reduce your banga, your glaucoma or your pressure in your eye, you will be stoned all the time. You will be so psychotic in order to have an effect, because you have to take it like 6 times. You need to take this like all the time. And the risk doesn't, the risk is not worth it for what you're going to gain. So there are drugs that are much more potent. You don't need to take them that often with less side effects than cannabis. So in the section, let's go to the core of our talk, which is glaucoma in Cameroon. I have a question to the chat, the moderators. I don't know, I see the chat blowing up. I don't know if there are questions or I don't know if you guys prefer. So yeah.
Please go ahead. There are a few questions in the chat, and I think they can just wait till the end of your presentation, Dr. Nche.
Okay, thanks. So for concerning glaucoma in Cameroon, what's the situation? I said before that 4.5 to 8.2% of Cameroonians that go to an eye hospital have a primary have a glaucoma, okay? And this I want to highlight that these are people who went to the hospital. These are people that something happened to them or somebody referred them and they went to the hospital. So this does not really reflect what's happening on the street, what's happening in our quarters, what's happening at home, okay? This is a paper that was published in 2011 on the prevalence and causes of blindness at the Hôpital Général in Douala. And they reported, you can see here, that primary open angle glaucoma was the second most common cause of blindness in that setting. In this paper, 19.7% of 927 patients that they looked at had bilateral blindness from a glaucoma. 14.1% of them had unilateral blindness from glaucoma, and 10% of bilateral blindness in children less than 10 years was due to glaucoma. This is not good, because the first cause of this blindness is cataract, and cataract can be treated, but glaucoma, there's nothing that can be done about it. So what are the associations in Cameroon that have been reported? 15% of diabetics that were referred to the Douala General Hospital had glaucoma in their worst seeing eye. About 11% of children less than 5 years with eye malformations have congenital glaucoma. Glaucoma is the third reason why eyes were recommended to be removed at Ajgopi in Yaoundé. This should not be. 0.4% of people aged 10 to 35 years that were seen at an eye hospital had glaucoma. this is a young population, and it's just upsetting to think that these are people that actually went to the hospital. And amongst them, this group of people, 88.3% of them had a positive family history of glaucoma. So you see that these are people that, if just from the fact that somebody in the family had glaucoma, they had been screened earlier, most of them would have been caught up on time. Still, amongst this group of people aged 10 to 35 years, 25% of them had total cupping. By now, we should all know what is total cupping, meaning there was no optic nerve. It was just a cup, meaning they don't see at the time of this. So what treatment options are available in Cameroon? Most eye drops, I think, are available in the big cities, but they are expensive. Some of the drops are between 10 and 15,000 francs. And if you have to use these bottles for, let's say you have a drop you put twice, each bottle is supposed to last just a month. And there are people that need about 3 of these bottles every month to use. So it's really expensive. It's just some few centers have lasers for glaucoma treatment available. And and surgeries like trabeculectomy with or without mitomycin C are available in a few select centers. So I put this it's a graphic that shows the global distribution of ophthalmologists per million people in a population. You see, Africa is basically inexistent on this map. You just see North Africa and that's it. Because in most African countries, like we all said at the beginning, ophthalmology is not really a priority. You know, we have bigger problems, like we say. And we see here that Cameroon is in one of those places that are non-existent on the map. According to the International Council of Ophthalmology in 2016, there were 3 ophthalmologists per million people in Cameroon. Just 25% of them had some surgical skills. Most of them are found in the big cities, which is Douala and Yaoundé, which explains the lack of access to care, the lack of awareness, the late diagnosis, and all the gruesome figures we just looked at. What I just put here where we have eye care services available in Cameroon. We have in the public hospitals and the big hospitals in Yaoundé, in Douala, some few regional and district. When I said district hospitals, yeah, I was just talking about Douala because I know there's no district hospital in the other regions that has an ophthalmologist. There's a new center that was created in Obac, the Maghrabi ICO Cameroon Eye Institute, which is, I think, the best center so far in Cameroon when it comes to ophthalmology. I'm not here to sell anyone. I'm just talking about the realities on the field. You have the Baptists and the Presbyterians that also have a good network, and they are doing a good job when it comes to ophthalmology, and some few private institutions scattered in some places. So what can be done to make things better? So I structured it like this, okay? We have to start with our own individual selves. What can you do at your own level with your own immediate environment? What can be done, okay? You can start by you going for screening. Like I said, just being of Black African descent, you are at risk for glaucoma, okay? So go for glaucoma screening. Every now and then you see these posters on the streets. HGOP, Hôpital Général is doing free screening for glaucoma. The Baptist and your quarter, they're doing free screening. Go screen yourself. Don't say, oh, I'm fine. You know, I don't have any symptoms. Like we see you have glaucoma and it's killing you and it's destroying your sight and you don't know. Go for screening. Check your family history, okay? Ask that blind pa, that my blind uncle that was like, what was he blind from? When I took him to Acha, what was he blind from? If you hear glaucoma, my friend, you are at risk for glaucoma, go check yourself, go check your family members, okay? Screen your families for glaucoma, educate yourselves, that's why we are here, know more about these things so you know how to better handle them. And if it so happens that you have glaucoma, be compliant. It's pointless not to be compliant to know you have glaucoma and not do something about it. Most of us healthcare professionals, we are the worst patients. We preach all these things and we hardly ever do them. We should be compliant if we are so diagnosed with glaucoma, okay? Now, what can we do as healthcare professionals? We can continue educating ourselves. We can create awareness concerning glaucoma in primary care settings. All these things are highlighted. Most of us, patients come to, and last thing we want to do is check vision. I'm not so sure. I'm not trying to criticize anybody. Most of the things I say is from my own experience from when I was a general practitioner, okay? I don't remember checking anybody's vision with a visual acuity chart. So I want to think there are many other general practitioners out there who see a lot of people who, some of them even have visual complaints. Nobody goes to check their vision. Advise how to use a direct ophthalmoscope, okay? Because we are the ophthalmologists where we find ourselves. If there are 3 ophthalmologists in Cameroon, 1 million people, and these people are all found in the big cities, it means that you and I working in the periphery, we are the ophthalmologists for the people we see. Let's learn how to use our ophthalmoscopes. As you use it, you get to practice, you get to understand how these pale nerves look like, how these glaucomatous optic nerves look like. You can look at an optic nerve and say, this looks like glaucoma. Go to so and so place to get better treatment, and let's refer them early. If we suspect these things, let's refer them early to the right quarters. And collectively, as a nation, as a people, there's a lot we can do. That's why we're here, okay? We can create programs for population-based screening and actually make sure these things are done and followed up for the right reasons. We can have programs for patient awareness, education. That's why we're here. January is a Glaucoma Awareness Month. When I was talking with Mono, we debated about so many things, and I was like, no. It's a Glaucoma Awareness Month. I am not a glaucoma specialist. I'm talking here as a general ophthalmologist. What I do is cornea, cataract, and refraction. But I thought this was a good time to talk about glaucoma. We can upgrade our healthcare facilities. There are healthcare facilities that don't have a visual acuity chart. So there's nobody to, if it's not available, who uses it? Many healthcare facilities don't have direct ophthalmoscopes. So how are we supposed to use them, okay? We can educate if we have ophthalmic personnel, we can educate them. We can integrate eye care into our existing systems. If every district hospital, if every chief of health center knew how to measure IOP. Nowadays we have IOP machines that can be used at home. We have mobile or IOP machines. It takes 5 minutes to learn how to use them, okay? This can be put at the periphery if we so want to. So we don't need to wait when we have big centers that would train ophthalmic personnel for us until when there will be so much that we can see the guy in the periphery. To do these things, we can integrate eye care into our already existing systems and create a change. And what's there for the future, okay? There is something called teleglaucoma. Nowadays, we are here, we're all talking. We didn't need to, I don't know, meet at a conference somewhere and all see each other in order to share this knowledge. Meaning nowadays, a lot can be done, okay? There's smartphone-based testing. Recently, there was a paper from Cameroon about a smartphone system that was used to look at optic nerves. Their conclusion was that it still needs to be refined, but these things are possible, okay? Now there's artificial intelligence and deep learning, and a lot can be done. Collaborations can be done to save the sight of the people we love, okay? This is our country, and if we don't do it, no one is going to do it for us. So to conclude, let's leave this place with some few messages, okay? Let's remember that glaucoma is an optic neuropathy. Okay, it's just not an eye disease. It affects the nerve, and it often presents with high intraocular pressure. It's the main cause of irreversible blindness worldwide. The burden is in Africa. Screening and early detection and prompt treatment can go a long way to preserve vision during a lifetime. Glaucoma poses a major challenge in Cameroon, while the risk for late presentation and early blindness is still very high. Emphasis should be placed on training, educating, and mobilizing even existing non-ophthalmology healthcare systems to reduce the gap. I will say thank you by sharing this picture with you. This is my friend, Dr. Sangawa Carlson, who is an anesthesiologist here with me in Israel. And this is him. He came here, he came for a screening. And you can see here in the corner, somewhere you see his retina. That was me checking his eyes. So it starts with us, okay? Thank you very much.
Thank you, Dr. Eleanor Ngwe. This has been really exciting. And I think the general message that I'm picking up from the comments in the chat is that you've just simplified ophthalmology in a way that is so beautiful and so easy to understand. A lot of people feel like their ophthalmology teachers did a horrible job in medical school, and you've just made life so easy for us. So thank you so much. And we know you've been talking now for more than an hour. That's quite a long time. So please just, feel free to grab more tea or coffee or water, what works for you, while we just check the temperature in the house to see how our town hall members are.
Okay, thank you. Thank you. It was a pleasure.
I see Louisa joined us. Hi, Louisa.
Hi, Alison. Happy New Year, everyone, the town hall.
Welcome.
Sorry, I'll just turn on my camera because I haven't seen people in forever. Sorry, I'm on call for obstetrics, so I'm just coming back from doing one of the things that we do there. It's so good to be back. Hi, everyone. Alison, sorry, I'm just grabbing the floor from you.
Take over, Louisa.
Yeah, thank you, Dr. Chair, for the presentation. Sorry, I joined really late, but I think I had my question answered even attending really late in the presentation. It was really easy to follow, well simplified, and seriously, I could pick up a lot of from the take-home messages. I could tell exactly what was said initially, and thank you so much for making our time.
Thank you.
Then we're going to check on the temperature with Kevin Jeffy. Hi, Dr. Jeffy, welcome.
Thank you, Alison.
Yes, how did you find today's session? Maybe you just say hello to all the people in the town hall. Just tell us where you're calling in from, and then tell us what you feel, how you feel about today's session.
Yeah, hello everyone. It's good to be on the call. I'm not very frequent on the call, but one of the days I've joined has really been an interesting, exciting discussion. I'm following up the call from Dakar, Senegal, where I work now. So it's really been edifying, and like the comments have gone, Dr. Nche has really simplified ophthalmology for us. I think maybe in medical school, if I had a lecture like this, I should have been an ophthalmologist now. So it's really been exciting, and I really want to congratulate her for that. And I say, well, a job well done. Thank you.
Thank you.
Thank you very much. Dr. Bill Wingo. Dr. Wingo?
Yes.
Hi, welcome.
Thank you. Hi, everyone. And I think it's quite interesting to simplify such a complex subject. And I would like to really give it out to Dr. Ngwe, and to say that we have these bright minds all around the world who are doing wonderful things. And to accept to share their experience and their knowledge with us can only help to strengthen our own systems back here at home. And I would just say that she succeeded to inspire many young ones. I'm very sure about that. And equally succeeded to take us back to our basics, which is very important. And for us who are in the higher spheres, we continue to see areas where we can influence our policymakers to throw an eye in. And therefore, I want to thank her for her presentation and to ask her to continue to dish out such digestible knowledge from time to time so that we can continue to remember that we are still doctors, because sometimes I tend to forget that I'm a doctor. Thank you very much.
Thank you, Dr. Ringo. And please don't go too far, because Dr. Eleanor Ngwe mentioned that many hospitals are not doing a great job integrating eye care into the general, care of the hospital, of the patients at the hospital level. So now and then we might throw a few bombs at you, Dr. Ringo. Please don't go too far.
Right here. Thank you.
All right. Elvis, how are you feeling today? Because as for me, I feel like I'm going to switch career paths after this session.
Yeah, I'm feeling really excited. I was just laughing when Wingo says sometimes we forget. How can we, the eye is the window, right? We need to see Cameroon through our eyes. And if I were in Wingo's shoe to make the best of policy, I'll place eye care at the premium of my policy, priorities. Because if we get blind and we cannot see, then everything else is messed up. So eye care is really primordial. And I must say thank you to Dr. Nche for this really great presentation.
Thank you.
Dr. Nche, while you were presenting, there were a lot of questions in the chat, a lot of comments in the chat, and one of them was around when you mentioned the effect of marijuana and alcohol, on the eye. And people were like, how can you say marijuana is not good for our eyes? And they were kicking back. And, we did have a comment around alcohol being used for glaucoma and having some beneficial effects. So just debunk all these myths that are circulating for the people watching us, especially it looks like it seems to be especially for the guys in the house. Just tell them, the whole alcohol and marijuana thing is a no area for them as far as the eye is concerned.
And before she says that, let's be clear whether when somebody says, when I take that thing, I see well, is it seen through the mental eyes or through the physical eyes?
That should definitely be through the mental eyes. Okay, so I want to say this. Please, yes, there is a portion in cannabis that lowers pressure in the eye, okay? But like I said, the effect of the pressure lowering effect lasts for about 3 to 4 hours. And glaucoma, your pressure in the eye is high 24 hours on 7. So for you to maintain good pressure with this kind of treatment, you will have to take it like 6 to 7 times a day. But it so happens that the constituent in cannabis that causes the pressure lowering effect is the one that has a psychotic effect. So it means that for you to lower the pressure, you have to take so much cannabis and destroy yourself to be able to have that pressure lowering effect. And therefore, again, cannabis is not recommended for glaucoma treatment, not by anyone, except all the, you have the shamans and the gurus and all those people who are always high and stoned, and they will tell you, okay, it's good, you have clarity, like Elvis said, you start seeing clearly. Definitely, it's not the scientific eye. And also for alcohol, yes, has this pressure lowering effect, which lasts 1 hour. So if you have to take a drug that has an effect that lasts 1 hour, it means you have to be so high on alcohol all the time to lower your pressure. And please, my melanin is coming to my brain. The words are coming in French. I want to say les effets nocifs because I don't have the word in English in my head. The adverse effects are not worth it. Are not worth you using alcohol or cannabis to lower your eye pressure. We have eye drops that you can use twice daily. Why use cannabis that you have to use 3 to 4 times a day and actually become psychotic just to lower your pressure in the eye? And the other part of cannabis, which is actually the part that made cannabis legal in the US, because now there's medical marijuana in the US, right? Which is CBD. CBD actually increases pressure in the eye. So this whole cannabis thing, please don't do it.
Hello.
Thank you, Eleanor. We have a few senior colleagues in the house that we just can't go on without acknowledging. I see Dr. Charles Array is here with us. Hi, Doc.
Hi, Alison. Happy New Year.
Same to you, Doc. Welcome, welcome. It's such a pleasure to have you.
Thank you. Thank you. The pleasure is mine. And it's rather unfortunate I joined the house late. As a father of a son who is being followed up for glaucoma, I think this town hall would have been very, very interesting to me. But that notwithstanding, I wish to thank and congratulate our own very Nche, Eleanor. I think I am one of the pillars when she started this journey to Israel. I think I feel very, very happy. We are reaping the fruits of the seed we planted. That notwithstanding, the only question I have for my Eleanor is what efforts is she making to see that many more people get into her field? You know, when she gives statistics of 3 ophthalmologists for 1 million Cameroonians, I think there the problem starts. There the problem starts. So like we say in Africa, when you're climbing, stretch your hand and hold others along. What other efforts can we make so that many more GPs get interested in eye medicine? Thank you.
Thank you, Doc. Thank you, Dr. Array. You're one of the seniors that, like you said, pulled me up. You know, those are the fathers in medicine. Thank you. So I think this town hall is really one of those things. I think it starts with a conversation, okay? When I got into ophthalmology, I realized, oh my God, there's so much they don't tell us in medical school. And I think it's in having these conversations that people, first of all, have to pick up the interest. And because ophthalmology, it's so controversial that when you go out into other places, ophthalmology is a top specialty everyone wants to get into, because this is like the money-making machine in other places. But in Cameroon, I'm sorry, I'm saying this on record, people think you go to ophthalmologists because you don't want to take on calls. There is this false conception that, the easy guys or the people who want an easy life, they go to ophthalmology. Where I trained, we took calls. I mean, you take a call where you don't sleep the whole night because you're working the whole night as an ophthalmologist. So I think it's just this lack of awareness, because we don't have a platform where things are being done. If only 25% of Cameroonian ophthalmologists have surgical skills, it means that a good number of medical students don't even know what is available in terms of ophthalmology when they do their rotations, meaning there's really nothing that encourages them to say, when I saw a laser refractive surgery and in less than 2 minutes, somebody's vision was changed, I was like, wow, I never saw this in my life. When I saw a corneal transplant surgery, I remember screening people in Bamenda and for a cataract eye camp, and there were people who had corneal problems. They were just kept aside because they were like, there's nothing to do with you. That's it, you're blind, goodbye. So we first of all have to start with national programs that think ophthalmology is priority. That's the first thing. I will talk about it. I encourage people. I have someone who's training here because somehow he got to me, and through me he got here, and now he finished training and he's doing his fellowship in retina. That I am just one person. I cannot reach 25 million Cameroonians. We need programs. We have programs in the ministries that have to sit and say, we have a problem, we have to fix it. We have one training program in the country that trains, I saw online it's 8, but I know when I was there, it's about 4 people a year. And in this number of people, most of them will end up working in Yaoundé and Douala. We have few people that were trained in Nigeria or something like that will come back to work. And because of the conditions, wouldn't want to go to the periphery. These are problems. We need policies. I hope that you people who are in the policy-making places will put in good words also, not just for HIV and diabetes, but also for ophthalmology, because what is life without vision? What's life without sight? I think we should get past the point of, if I'm not sick and I'm feeling like I'm dying, I'm healthy. There are other things that make quality of life good, and we should look at these things. I've had to have conversations with intellectuals who have lost their vision from glaucoma without knowing in Cameroon, and that is not something we should encourage. I hope I answered the question, Chief.
Thank you so very much. I will relate that to Wingo, who is in Yaoundé. Those who work in Yaoundé are policymakers. I am in Kenya, eating ugali and nyamachoma. Thank you very much, Elena.
Thank you, Dr. Ari. Dr. Nche, we do have a few questions in the chat. I think we can take on some of those questions and then open it up to those who are here with us on the floor or to those joining us via social media platforms. So some of the questions include, can we have severe headache in both open and closed angle glaucoma, or headaches are more with the closed angle glaucoma? I know of a young guy in his 20s and he's always complaining of headache.
Okay, you can have headaches in both of them because the mechanisms lead to high pressure in the eye. So usually the person who has a open angle glaucoma, it will take them a while before they will have a buildup of pressure. And the person who has angle closure glaucoma, usually it's an acute event. It's like everything was fine and all of a sudden, boom, intense headaches. Those are the people that rush to the hospital at 3 a.m. because they have this eye pain that, you know, so both of them can come, so long as there's this high pressure, it can cause the headache. So both cases. And if this person is saying they know someone that has been having headaches for a while, now they should know what to do. You need to see a neurologist, you need to see an ophthalmologist. Those are the 2 things you need to do.
Okay. Then there's another question around whether you can have normal or high pressure, whether you see more normal or more cases of high pressure glaucoma in your practice.
Okay, I work in a tertiary hospital where most people who come have already been seen by a general ophthalmologist in the periphery before they come. So I see more people with high pressure, but that's not the reality on the ground. That's not the reality on the ground, okay? Because these people come, if I use my experience, it will not be reflective of what's happening on the ground, because I see people who come because another ophthalmologist already saw them, they had a problem and sent them. So my experience will not be the reality of what's happening. I see just sick people. I don't see people who come to screen for glaucoma. I don't see people, I'm not in glaucoma screening programs. I see sick people.
Okay. And then there was someone wondering about how prevalent glaucoma is among drivers in Cameroon. If you know of, and the person was wondering if you know of anything that's been done to ensure that a vision test is mandatory in order to obtain a driver's license in Cameroon.
This is something that I'm quite interested in because I wrote a paper recently on this, not on glaucoma, but on vision testing in drivers. The whole story of drivers and Cameroon goes close to my heart for those who know me personally. So we went and looked at drivers in Boya and Limbe motor parks because we wanted to know what's going on with the vision. Maybe it's not just the bad roads and everything that goes to Cameroon, and And we had bad numbers, like we have like a good number of drivers. I think it was about 10% of drivers that didn't have good enough vision in their better seeing eye. And most of them, more than I think 80% of them or something like that, I don't have the numbers exactly, had not seen an eye doctor like for the past 10 years of their driving experience. So it's not that it's just the drivers. I'm very sure if we repeat this study amongst doctors, we will have a lot of doctors that don't see. I have doctor friends that is because of their relationship with me that they complained about something and I put their, I talked about something and they had to go and check, and then they realized they had eye problems they were never aware of. I have friends who tell me, I was in medical school and I was never seeing clearly. I always had to go close to the board. Nobody ever checked that this was glasses problem. This is just one of the many, many problems. I'm talking, these are doctors. So imagine what could be happening to the guys who is not a doctor, whose health is not his priority, who just wants to make his money. The numbers are bad. And we need people to do these studies. I'm very interested in all of this. Soon I will be in Cameroon. Hopefully the environment will be letting me do what I need to do. But I'm very welcome to talk with anybody who is interested in all of this. These are things that are close to my heart. I don't have exact numbers for glaucoma, but from studies that we read about similar studies that were conducted in Ghana and Nigeria, a good number of drivers have glaucoma and they don't know.
Okay, thank you for that response. We have a question, a comment and a question from Anne B, and I'm going to be really glad if she could even elaborate further if she would love to. She says, I do receive a good number of diabetic patients with visual impairment. I get uncomfortable when a patient's diagnosis is not confirmed. One ophthalmologist says the patient has glaucoma, patient starts treatment, but another rejects the diagnosis. Anne B, welcome to the town hall. I don't know if she's still here with us. Yes, she is. Okay, maybe she can't unmute herself, but maybe do you have any comments? Oh, there she goes.
Hello.
Hi, Anne. Oh, yes, you're welcome.
Hello. Thank you, Alison. Good evening to everyone. Yeah, I was talking about this worry that we have. I'm an endocrinologist and I work at the Yaoundé Central Hospital. It's quite embarrassing for us sometimes to have this diagnosis that is not confirmed. You know, you refer a patient to an eye specialist. One tells you that the patient has glaucoma and he even starts treatment. And later on, when the patient decides to consult in another hospital, he comes later on and he tells you that it wasn't glaucoma. So what do we do in these cases? Do we have to send our patients around, moving from one eye specialist to the other? And I've had this several times. I don't know if it's that the diagnosis is difficult in our setting or what is actually the problem. Is it about the criteria or what? Because many people, even in my family, some people have complained about that. Going to one specialist, having the diagnosis of glaucoma, and then going to another one who rejects it. Thank you.
Okay, and I'm going to talk to you. You're my sister friend. Anne is my classmate, so I know Anne. Okay, so and I'm going to tell you this. The glaucoma, the diagnosis of glaucoma has certain criteria that has to be put together, and it all now will depend on the competence of the person speaking, and also what these people have access to. Okay, now I haven't been in Cameroon for a while, but I know there's just one center in Cameroon that does what I showed, OCTR NFL, and it's the center in Obak. And most people who get to me, I send them to Obak because I know what they have there. Most of ophthalmology is our machines and the things we use, okay? You can have a clinical suspicion, but you want to confirm. And most places don't have these auxiliary tests to confirm all these things. I've had patients that I sent to one ophthalmologist and they've treated them for glaucoma and they even wanted to do glaucoma surgery. And then the patient was hesitant and I was like, okay, let's take you to some other place, which I knew had a better competence, technical level. And when I went there and they showed me the images from there, I said they didn't have glaucoma. So these are all the things that we have to put together. We don't have the machines. We don't have those things. So I still want to sound political, but I will say that it's better if some of these people tag these things as glaucoma suspects. There are things that they call glaucoma suspects. So this person is, you might have glaucoma, but you need to do this and this and this and this. And I want to go back to say, we are in a very, very resource limited setting. What they call the BEABA, or the basics of what is needed for ophthalmology, we don't have. We don't have it. So I will still go back to the center of OBAC. If you have any such cases that, you know, are kind of falling in between the cracks that you're not so sure of, and the people can afford, send them to OBAC. Whatever comes from OBAC, consult with me and I will confirm with you if it's right or wrong. And I will want to put my finger on the fire that the best diagnosis will come from OBAC. I'm really sorry, I'm not publicizing anybody, I'm just saying what I know.
Okay, thank you. Thank you. I think that's what I'll be doing. And I'll just get back to you whenever I have any of these cases.
Yeah, I'm available. Something I can help with. I'm very available.
Okay. Thanks for that response. And thanks, Dr. Anne Boli. Dr. Anne Boli is one of our senior colleagues, and she's a specialist endocrinologist in Yaoundé. And we're even looking forward to having her at the town hall in in some upcoming sessions. So there was a question in the chat, and Dr. Nche, around the intersect of telemedicine and ophthalmology. So we have Dr. Emmanuel Fombu here, whose main area is in artificial intelligence. And, you know, I'm sure there might be a nice convergence in terms of, or potential for artificial intelligence within your field. I don't know if Dr. Emmanuel Fombu had any comments pertaining to that.
Yeah, I could probably, can you hear me?
Yes, we can hear you.
This is probably the best forum, by the way, that I've ever met of Cameroon doctors. Right? I think it's incredible. I didn't realize that we're all doctors from Cameroon, but across the world. Like, I didn't realize that. So first of all, it's great, and thanks for having me. And Dr. Nche, I'm glad you're in Israel, and I actually spent a lot of time in Tel Aviv and in Jerusalem quite a bit, right? And AI is like a big field in how we develop things there. I've done projects, which I'll talk about next week, the next time, February 26th or something. I'm sure you'll keep me posted, Alison, around even training AI systems in Rwanda, in Uganda, right? And those systems have been deployed in the US and deployed in Mexico and deployed in Germany. And I think that what we can leverage here is we have experts. We don't have to be in Cameroon to make these things happen, right? Because if you try to build a health system, I'll spend time talking to health ministers, because Africa and policy is a waste of time and space, right? There's no point talking to them, right? I think that things we could do today, where we could have colleagues that are in Cameroon that could have patients that could consult with us through a basic WhatsApp or what a call to just diagnose those patients in a short-term basis, right? Technology is something that we can scale. Everyone has phones today. We could take images and do a lot of different things. So I think they're very interesting things. I'm curious about, is there any kind of telemedicine kind of infrastructure in Cameroon that exists? And are there things that we can do to make things actionable, to say it doesn't matter where we are, we have expertise in it. We could leverage everyone in this forum to say, hey, we're available. We could leverage our colleagues in Cameroon to say, hey, make an appointment. We can see some of these patients that no one else will see them.
Okay, thank you, Dr. Emmanuel. Thank you. So to the best of my knowledge, there's as of now no telemedicine going on in Cameroon. If someone has some other information, they could put it in. I know there were plans by one center to start telemedicine, but it didn't really take off. So but like you said, these are like really, really basic stuff. Everybody in Cameroon has a phone. Everybody in Cameroon, someone has Facebook, WhatsApp. And I've had to intervene in cases from here. Like from here, I've had discussions about cases from Cameroon. Of course, I'm not going to do anything from this end, but sometimes just telling them, giving them the right orientation or giving my opinion helps. I think these are things that are very possible. I'm optimistic about what can be done in Cameroon, most probably to afford, because I seriously believe that what it takes is a will. What it takes is a will. There will always be challenges. What does India have that we don't have? There's a lot of telemedicine in ophthalmology in India. They've done a lot. They are doing so much. They have centers where you have people that have just basic first school living certificates that are taking these images and sending it in the district like this, or maybe the ones, all these, and you know, a lot is being done. Cameroon is just 25 million. India has a huge bulk of poor people. Okay, so I believe personally that we can do so much, but we just need the people that have the will to do. I believe if somebody had talked about doing a Cameroon town hall 5 years ago, so people would have said, oh, it's so impossible. How will you do this? How will you do this? How will you do that? But right now, this is the 42nd edition because some people sat down and they had the will to make it work. And so it's working. So I think that's all we need, the will.
Thank you for that response, Dr. Nche. And just to also say that there've been, even just within the town hall, quite a couple of collaborations between members of our town hall and people working in Cameroon, even in some really constrained settings. We've had, for example, our chairman, alongside with other senior colleagues like Dr. Brunhilda De Santos and Dr. Kenji Obadia, who at the peak of the pandemic were able to collaborate with colleagues working mostly in the Northwest region in the management of patients with COVID, and there was learning happening on both sides, and it was just an amazing experience. So just to corroborate your point that it's truly about the will and the desire to bring change. You know, once you have the will, it's going to happen. We have our chairman whose hand has been up. Dr. Muno, please take it over.
Alison, thank you very much. And Eleanor, thank you very much for accepting. And it's been a wonderful session. I'm one of those who said if my ophthalmology professors, who call themselves professors, had taught this topic like this, I cannot forget the day I was taught. One of my classmates, Ombako Kingsley, said the same thing. The day we taught this topic, when I was sitting in the amphitheater in Hughes, I think that's the day I stopped thinking about ever doing ophthalmology. It felt like a mystery beyond all mysteries that I have to unfold, which I could not really unfold myself. I don't know if it was a language or it was just, but I've had difficult language going through sessions because the anatomy in the first year was crazily difficult in the terms of the language, but I think it was the way it was delivered. So I want to thank you for showing us that we can deliver knowledge like this. And a lot of people in the town hall, all our presenters have done similar things, which I'm very grateful about. And we can just, listening to you and listening to Anne Boli talk about the issue of problems with diagnosis, the issue of having physicians who need continual education, we need to get to a point of accepting some of these things. That we are in a field where we need continuous education, we need collaboration. We need to learn South versus North education is something that you learn from one another. I learned a lot when I've either collaborated with colleagues home. I know exactly nurses, lab technicians, physicians, midwives. I know that they are very intelligent people that if they move here, they will do the same thing I'm doing. So it's not a matter of how intelligent they are, it's a matter of access. It's a matter of trying to update your knowledge from what you have. How do you feel medical education in itself, nursing education, and can be integrated in such a way that we put ophthalmology at the same level, or even not the same level, but at least at the level where medical students would feel that this ophthalmology lectures, or those who are delivering these lectures would feel that it's important. Because I think the primary care doctor or the GP is not even taught in medical school to know that ophthalmology is important. So why on earth should he even refer these patients? I never referred anyone when I was working in the regional hospital in Bamenda to an ophthalmologist. I don't know. I worked in Mancon, you know that very well, for at least a year. I don't think I referred. I did refer some people which I saw with other things that could be eminent, but really there were many of them that I had missed, and it was lack of knowledge. The first thing was that I did not have the primary knowledge to even know these things. The second thing was that I was not trained to feel that it's important to refer these people. The third thing was I was so consumed into dealing with things I'm comfortable with, meaning that dealing with things I know already is associations, associating things I know, things that I don't know about, I really did not take notice of them. So how do you think we can go back and integrate this in medical schools, advocate for policy to change? I think you're in ophthalmology, so I'm going to do that with ophthalmology. We can do that with many other things. I'm in oncology, and I'm really looking forward. I'm giving you my plans. I'm creating, going forward, a platform where I would want to give collaborating lectures and discussions with medical students all over, Boya, Bamenda, Douala, Yaoundé, where they can come in, we can discuss different cancers, because I have seen a loophole in the way cancer patients are managed, especially breast cancer. So it's just one of those things that I want you to think about and see how we can influence policy in terms of medical education, nursing education, and others that can affect the field.
Yeah, thank you. I think we have to start with people who, we are a new generation of people, okay? Like you said, we all went to those medical schools where learning was like a task. It was like an uphill climb, something you had to move to the next class and get out of there. I think we are that change that has to happen. And I think we have to speak with policymakers and show them, if they will be so willing to want to accept change, there's a different way of doing things. It's about nurses and integrating nurses into all of this. I want to give you a story. I want to tell you a story. My department has a history of being in Africa for many years. So they've trained a lot of people from different places in Africa. And there's a guy called Moses Chirambo from Malawi. He went back to Malawi after he trained here. That was like donkey years ago. And he started training what is called ophthalmic officers. And these are people who are just like nurses. And they were trained to a level where they were doing cataract surgeries. And this is how, the level went up. That's why I don't believe that we should wait for the 4 people or 5 people that will be trained every year. First of all, many people don't know this, but in ophthalmology, you have the optician, you have the optometrist, and you have the ophthalmologist, okay? And in Cameroon, we have just one place that trains ophthalmologists. We don't train, we have something in Yaoundé that trains les infirmiers spécialisés en ophtalmologie, and that's it. We don't have an optometry school, we don't have opticians, and no, it's just a mess. So if you meet some guy who is selling glasses, he passes for an eye doctor, everyone passes for an eye doctor. So we have to go back and look at our training centers and reform our trainers. For me to want to do ophthalmology, first you want to make ophthalmology interesting to me. So we have to, I don't know how we're going to do it. Maybe it's through these conversations, then one day we'll get to a place where we talk with policymakers. This be ophthalmology in every other field. I believe that if an ophthalmologist who works in a regional hospital takes it upon themselves to train the nurses that work in the CMRs around them and the chief of centers around them, just how to do proper fundoscopy, look at the optic nerve. To diagnose a cataract, you don't even need an ophthalmoscope. You need the touch light of your phone to look at an eye and say this eye has a cataract. If we can do this, okay, and say, okay, all those ones you see and you suspect, send them to me. We can do all of this if we have the right people with the right intentions. It goes back to intentions. That's just what I'll say.
Thank you.
Okay, thank you, Dr. Nche. And we'll take a last question from Brian, after which we have to round up. But please remember that we have the parking lot immediately after, and we'll be celebrating the AFCON win. There's already provisions for palm wine. Brian, please take it over.
Thanks, Dr. Chair. I think that was really great presentation. I've never really had a lecture more simplified than what you just did today. Thank you so much. I had a question primarily first for Emmanuel Fombo. I think I heard him say he works with AI. I want to know more about what you've seen in other countries and the integration of AI technology and potential application in ophthalmology. So lessons learned from what you've seen in other places, how I think you mentioned Germany and a few other countries. I'm really curious about what the impact that AI can have in the ophthalmic care, particularly in Africa. I think in Africa, we have a problem of access to healthcare. So I think we can we can decompartmentalize that. I think that's going to make a really huge impact. Dr. Chair, the question I really I wanted to ask you is this: the prevalence of normal pressure open angle glaucoma. How? Yes, because I think that's one significant cause. I don't know, it's in general one significant cause of blindness, but how prevalent is, I guess you see patients when they have, you do an IOP and it's high, but what about those who have normal pressure? How prevalent is that as well? And any, my dad is visually impaired because he has an eye that was damaged by, got untreated, it was damaged by glaucoma and still resulted in retinal detachment, and he's not been able to see from one of his eyes for long. So I'm really curious about, and that went undiagnosed for a long time because he had normal, his eye pressure had been normal throughout. So really curious about that and how we can help improve screening for glaucoma in Cameroon, in Africa. Just your thoughts on that as well.
Okay, thank you, Brian. I will not have exact numbers in my head, but I want to say that a good number of all those who come later with pressure, they usually start with normal tension glaucoma. There's this huge discussion in the glaucoma settings of if normal tension glaucoma is actually a subset of its own, or if it's just the regular primary open angle glaucoma that is in its onset and the pressure hasn't been high yet. In Africa, I don't really have numbers. Not much has been said in our African setting about normal tension glaucoma, things most people presently. Now, about the screening, I want to say that there are smartphone technologies that you can give a nurse in a district hospital somewhere with the telemedicine thing. All they need to do is dilate the patient, take a picture, and send to whoever has to look at them at these fundus pictures. Pictures exactly like what I showed in my presentation. That after my presentation, I'm sure most of you, if you will see such pictures, you can already say that, this nerve I'm seeing is suspicious of glaucoma. And then that particular person will now have to move to the next level. Okay, see an ophthalmologist, do a visual field, do an RNFL to confirm if this suspicious nerve is actually glaucoma or not. And I think in our setting, we can even create systems where the moment you see a suspicious nerve, you might even start treatment, before the person, because the person has to gather themselves, look for money, maybe look for money for lodging in I don't know where they have to go and do maybe 2-3 days before they finally see the person they need to see. Before they get treatment, it might take time. So I think these are solutions that we can put in place. That's why I say we need to use our non-ophthalmic personnel to do these things. Glaucoma is a problem in our communities. Like you said, There are people who are going blind without knowing. They go to the hospitals, and because we are fixated on this idea of glaucoma is a pressure disease. So I went and my pressure was normal. Oh yes, I'm fine. That's the silent thief that comes and takes away our sight. But thank God for days like this and where we talk about it and now we know better on how to handle things. I hope that we will have the opportunities to create trainings, where we can train our nurses in the periphery, where we can train our GPs on how to identify these things, send the right places to get treatment on time. I'm very sure that the basic glaucoma treatments should be available in the, this is just me hypothesizing, they should be available in the special funds for health and things like that, where people should be able to get these drops. No, I don't know, where people should be able to get these drops. Lasers are good, but they are expensive. The trabeculectomy surgeries, you need someone who is skilled in surgery, and this will be maybe like one ophthalmologist in a million that has a surgical skill that can do this. But it goes back to early detection and sending them to the right place. And I'm saying again, I will be in Cameroon. It's something I'm passionate about. I will be in Cameroon, and I'm very open to whoever wants to talk with me. We work together to do what we can do, okay, in our own lifetimes.
Thank you, Dr. Nche, and thanks for those great questions, Brian. And with regards to further reflecting about the possibilities of AI, I think we can keep that for the next coming couple of weeks, where we'll be diving a little more into it. So maybe for the interest of time, Elvis, I see your hand is up, and I think Elvis's question will be the last as we are preparing to round up. We've taken a lot of Dr. Nche's time, and thank you for being so gracious to us.
Yeah, thank you, Alison. Thank you, Alison. You can see the town hall is so infectious. I'm shoveling the snow, but I keep listening to it while doing this. And it snowed very much today in New Jersey and New York. So my question is just about, you started your presentation with a very important experience of a child who is not able to see because of eye problems. And I think this is what is happening to a lot of kids, that we have labeled them as dull or not intelligent, but nobody knows what they are going through when they're in the classrooms and they cannot see the board and they cannot see what the teacher is writing. So maybe is there a way we could think about how to convince the Ministry of Secondary Education and primary education, maybe to just institute some kind of basic ophthalmic screening before kids get to school, just so we can identify some of those kids and really solve their problem. I remember my son, who is 11 years old, just called from PSS that he could not see the board well, and I sent him, and they realized he had a problem with his vision, and we got him an eyeglass, and that could be something that would have impacted his performance so terribly. So I think this is a very important thing that cuts across the educational system, and we could help some of those kids that will never know that that's their problem, but we'll label them as dull, and they can drop out of school because of that. So maybe can we think about the way like educational sector done prior to enroll?
Thank you so much, Elvis, for that really pertinent issue that you brought up. You're the only person I think who has talked about the kids, and thank you for that. So yes, in other places, this is what happens. Children are screened for vision at birth. They are screened again by the time they are 6. They are screened again by the time they go, by the time they turn 5 or 6 before they go to school, and even in school. And that's how these children are caught early and they are managed before things go really bad. So yes, I agree with you. There's so much we need to do. Ophthalmology, I will use this as to do a coup de coeur and encourage people who might be wondering, what specialty should I go into? There's a lot that still needs to be done in ophthalmology. Ophthalmology is that blind spot in Africa and Cameroon most especially, where there's so much that needs to be done. One doesn't know, like, I'm not talking about specialized care. I'm talking about the basic stuff. Like if we just need to train people to just know how to do a vision test, that will be amazing. Think about the number of people that get, I was having this discussion with some friends, some of them are listening right now, how we have a huge number of Cameroonians that have driver's licenses, that's with medical certificates that say they are fit to drive, and none of them have ever done a vision test. We have a lot of doctors in this forum. How many people in this forum, as we are talking right now, have signed a fitness to drive certificate? And before that, they did a vision test for the patient. And then I will go back again and ask, even if you did the vision test, do you know what is the required vision that someone is fit to drive? So that's to tell you that we have so many public health problems when it comes to ophthalmology. The children part is just one part. We have retinopathy of prematurity. We have a lot of premature children in Cameroon that will be blind and will be blind all their life just because they were born premature. And nobody ever thought, let's look at these premature children because there is something called blindness in prematurity that has to be checked and managed. We have these problems of glaucoma. We have the glasses problems. Glasses can change a child's life. And I'm sorry I'm taking your time, but I have to talk about this. Children who don't see when they are young, their vision doesn't develop. We should know this. Every child who doesn't see when they are young, the brain cancels vision. That part of the brain doesn't grow. So if that child crosses 8 years old and you go and discover this child needed glasses and you buy glasses for this child, the child's vision will not improve. It's called amblyopia and nobody is talking about this. I hope one day we'll have these conversations with the big people up there and they will hear these things and maybe it will affect them and they will see reason why, you know, we have to do all these things. Thank you, Elvis.
Okay, thanks for the response, Eleanor. And we have to start rounding up for today's session. Dr. Nche, we would love to keep you here all evening, but we understand that you probably have competing priorities at this time. Thank you for your time. This was an excellent session. Personally, I learned so much, and I'm sure that all the people who joined us on this platform today and those following us online equally learned a lot. And I can see that from all the questions and comments that are coming in. We are excited to see that you're already gathering the data and you're shining the light on all the problems that are currently existing. And we are looking forward to, you know, having our policymakers listen to you and make some of the recommended changes that need to be done in our setting to ensure our safety, the safety of our kids, and the safety of our communities. So as we prepare to round up, I'm just going to call on our different moderators to just give a word before we close this session for today. Maybe I'll begin with Brian.
Chair, I think everything has been said. It's a really great presentation. I really wish we had better educators like you in our medical schools as well. You really very well simplified this. It couldn't be haven't made any simpler. Thank you so much for doing this presentation on this very, very important subject. It was really great. Thank you.
Thank you.
Thank you, Brian. Maybe Elvis?
Yeah, thank you so much, Alison, for the excellent moderation. And thank you to all the other moderators. And thank you to Dr. Chair for this excellent presentation. I think you've used the eyes of your mind to see the problems even deeper than your physical eyes. And I think that this is excellent. And we need to continuously shine the light of this important public health problem. We shall work together with the town hall and you to see whatever areas we need to tap into to see how we can make the little changes that we can make. The town hall for healthcare professionals is here. Some people say we only come and talk, but as Muno always says, it starts with talking. If you don't talk about it, you can make a step towards solving it. So let's keep on talking about it, but let's also see how we can tap into some of those resources that can help us bring about change. Thank you so much to the chair for putting this topic at the limelight to the town hall. Thank you so much.
Thank you.
Christelle?
Merci, Alison. Merci, Dr. Nche. C'était très intéressant. Je ne peux pas dire plus que ce qui a été dit, mais ce que je vais dire, c'est que je te suis déjà sur LinkedIn et je me suis abonnée à Danka sur Twitter. Et j'invite tout le monde à le faire aussi pour continuer l'éducation et les mises à jour. Merci infiniment et beaucoup de courage dans la suite.
Thank you, Christelle. Merci.
Okay. Teresa?
Hi, I would like to first of all thank Dr. Chair for that good presentation. You've put a lot of information in my head. I've never really thought about vision because growing, I didn't have vision issues and no one in my family is really having vision issues. So, but I have friends that have issues with their kids and I'm like, I don't really know what to tell them. So at least I know where to refer them if they have those issues and I know where to go if I need help. So this is really good. It's very informative. It's sending me to the right places when I need help. And I think I'm gonna link in with you and catch up with you because I have a personal kind of issue. We can discuss about it, about vision and yeah. So I think if you can stay for the parking lot, maybe you answer my other questions.
Okay, thank you.
And Luisa, I know she was joining straight from a call. Hi, Luisa.
Hi, Alison. All right. Thank you so much, Dr. Chair. I don't know how to thank you, but yeah, thank you so much for making this Saturday really, I'm lost of words on how to say it, but yeah, that was a lot of information and thank you for throwing more light on areas where we need to improve as far as our education is concerned. And, like Dr. Fama was saying, it's about what we do individually, right? Like all the projects that he has in mind and, everybody doing their own little part. It's those little parts that come to create the big picture, that bring the big change. And really thank you so much for having those initiatives. And really, please don't give up, even if the people up there are not listening someday. If you keep bringing on their ears, maybe one day they would stop and listen and ask what this new generation is all about. So thank you so much, and please keep doing what you're doing.
Thank you, Luisa.
Dr. Nche, by the way, I already have my phone buzzing here. People are asking for your email, your number, because we have a few people following online who are like, oh, I need to see her because my eyes are messed up. So if you don't mind also dropping your email, at least on the chat, for those of us who are here and would like to reach out to you directly. We might have patients we need to refer, or we might have consultations that we need to be making. So we want to reach out. And I'm going to call on Dr. Foma, who is our chairman, to give the final vote of thanks to our speaker for today.
Wow. What do I say? I am fond of calling her Eleanor, so that's what I'm still going to do, Dr. Eleanor. And it's always a pleasure to see that you live in a generation where people grow and improve on things that they saw, meaning the way of education that we got while we're back in med school, the way you're passing across the information is spectacular. It's such a way that we can absorb it and be able to bring about change. And please, your motivation into ophthalmology can motivate others. You could start something where we can actually go into the point of really creating change makers in the field of auxiliary staff, nurses that would do the job that we had to do, or even aides that would help us get to that number faster if we're unable to train ophthalmologists. I think this is something that can be done. This is a project that we can go forward with. I just want to thank you for your time. I've been bugging you. I know you've been very responsive. I've been the one retracting at times. I come in and then I disappear for a while, but thank you for the presentation. Thank you for being a change maker. Thank you for seeing the way forward. And I really I used to doubt it. I had a friend when my first time there was one of the doctors who taught me when I was trying to take the medical entrance. I can't forget, he used to say area 17, 18, and 19 is the Kankaran region, which is responsible for vision. I was like, oh God. So we gave him a name. So it's one of those things where the vision, I've always wondered, that's just my thought process, that's something I wanted to do. I've always wondered why the human vision occupies the whole occipital lobe and is able to take care of things like that. And we just neglect it. The brain itself is full of an area which, without your eyes, your sights developing, your other senses become supernatural, meaning that it tells you how far the sight is really important. If you lose any other sight, you hardly develop anything supernatural. The only time you develop supernatural talent is when you get to lose your sight. So it's one of those things that I think we should have time. And I love the fact that you do talk about it in your platform. I want others to look at it. I told you I'm very interested each time a video comes out. And I love the fact that you do it in Pidgin. I love the fact that I get to see it in several other things. So I follow you on YouTube, and I watch the videos, the short videos. I've learned a lot from that platform. Now I'm not going to have a rock star we do have a rock star of moderators. I don't know how you guys do it, how you guys are still staying motivated, but thank you all. I just want to thank Crystal, Allison, Brian, Teresa, and Louisa. Despite your very busy schedules, you guys still succeed in contacting others who will come here and present to us. You guys succeed in trying to coordinate this whole thing. And I want to tell the others who are in the town hall, the platform is not owned by anybody. I'm just one member, and I hate being called chairman all the time, but it's one member that I am. I'm just a single member, and each and every one of you, I want a platform in such a way that if something happens in the future, you guys can continue it. Anyone can step up and continue it the way Allison stepped up, and Elvis also. And Elvis is actually one of those who discussed this idea with me. And Allison joined in such a way. It was a spectacular day. I don't want to go into the story, how we got to join. We had to have a debate. But it's very amazing that it's still going on. It's getting stronger. Please, if you know a Cameroonian who is out there and you think they're doing something that can change Cameroon, please let us know and try to bring them into the platform. Each and every one of you can do that. If you have a topic that you feel is something that needs to be debated in Cameroon concerning healthcare, we are more in healthcare, let us know about it. It could be a social issue, it could be anything that you feel that affects the health of our parents, the elderly, the pregnant women, the children, which is a special group in Cameroon. Please bring it up for us to talk about it. And I think we have been criticized by the fact that we talk a lot and we do little, but I want to tell you that the big things we have done behind the scene, and I'm not one of those who feel that we should keep creating groups. There are already people who do certain things. If we can partner with them, that would be wonderful. If we can actually bring them on this platform, we have brought, Glaucoma is one of those groups we have brought here. We've brought so many other groups that we can actually help them. They can help us in order to carry out certain goals. So we're looking forward to collaborating with others. So please feel free to invite your friends who are doing great things back home, and tell them they have a platform where they can actually talk about it. And then we can change Cameroon one loud voice at a time. So thank you, Allison.
Thank you, Dr. Fonga. Ladies and gentlemen, on that note, the 42nd edition of the Cameroon Town Hall for Healthcare Professionals is officially closed. And please join us in our subsequent town halls to talk about very interesting things. I can assure you we have excellent speakers lined up for you. For those of us here on the platform, please remember to stay behind for the parking lot where we have palm wine and fufukon with some katikati waiting to celebrate the AFCON. You have a great weekend, everybody.